All right, so I'm sure folks will continue to flow in, but we will get started because we have a packed agenda and a lot to talk about today. So thank you so much to everyone for being here with us today. We're all really excited to talk about the topics that we'll be discussing today, and we think it will foster some really important conversations. So we will get started. I am recording this session. But I'd like to start by just briefly introducing all who's on the panel with us today. So we have Emily Jones, registered dietitian and nutritionist from God's Love We Deliver. We have Maya Park, the manager of membership and accreditation from the Food is Medicine Coalition. We have Catherine Couch, who is the CEO and founder of Series Community Project. And we have myself, Makenna Koger, health educator, also from God's Love We Deliver. We have my colleague, Allison Schiff here, who will be monitoring the chat. So she'll be answering questions as they flow through in the chat box. I'd like to quickly run through our agenda for today. So we'll start with just a brief overview on the New York State Medicaid waiver. We will then move into an overview of God's Love We Deliver and medically tailored meals. We'll then have Maya talk about the Food is Medicine Coalition and the accreditation standards, and we'll end our conversation with the waiver experience in California as told by Series Community Project. We'll have some time for Q&A at the end as well. So we really look forward to some great conversations and discussions today. So this will be a very high-level overview of the New York State 1115 Medicaid waiver. Many of us on the call are probably quite familiar with the waiver, but this will just be a brief overview as to what it is, who might be participating, and some of the services that will be delivered. So the 1115 waiver at its core is really an effort to reform healthcare delivery by integrating social care services into New York State Medicaid. Many of us on the call have heard the term health-related social needs mentioned over and over, and these are those social conditions that really impact our health outcomes. So we know that individuals with unmet health-related social needs, or HRSNs for short, are more likely to have poor health outcomes and increased usage of healthcare. So really the effort of these waivers, which have been implemented in a few states, is to hopefully meet some of those unmet health-related social needs and improve those outcomes in Medicaid lives. So very brief overview, but all Medicaid members will be screened for unmet health-related social needs. Where they're navigated to after will depend on the population criteria determined by the state. But level 1 services will be navigation to existing federal, state, and local policies or services, and then those enhanced eligible individuals will then be shuttled to the community-based organizations that can deliver services that will hopefully meet some of those unmet health-related social needs. And that's really where community-based organizations, like many of us on the call and like God's Love We Deliver, are participating in the waiver. So we are able to provide the high-quality, evidence-based social care services that we have been providing for decades to these eligible Medicaid recipients and then be reimbursed for that care, which will be really transformative for many organizations. I have this map on the slide to show you the breakdown of New York State. So you'll see all of the regions, the counties, and then the lead entity or the social care network, as we call them, that is governing or managing that specific region. So if you have any specific questions about waiver-related activities, please reach out to the social care network that is managing your region or the counties in which you operate in. And when we talk about those health-related social needs, let's go back to the different services that are eligible for these Medicaid lives. So these are things like nutrition, increasing access to food, nutrition services. We have social care management, which will help with navigation to existing social care services. We have things like transportation and then housing. So of course, all really important health-related social needs that people need to meet in order to achieve their best health outcomes. Here at God's Love, we of course operate in the nutrition space, and we have done so for the past 40 years. So we will really be focusing on the nutrition portion of the health-related social needs services. And in this next section, we'll dive a little bit deeper into who we are as an organization and what we specialize in. So some of you might know, but our organization started at the height of the HIV/AIDS pandemic in the 1980s. Our core mission has always been helping to improve the health of folks diagnosed with chronic illness by alleviating hunger and malnutrition. And we really do this by providing our nutritious, high-quality, medically tailored meal intervention, which is key for helping individuals better manage their chronic illness. All of our services are free of charge. A client will never receive a bill from us, which is really important. And we've grown quite significantly since the 1980s. So this past year was a really exciting year at God's Love, but we cooked nearly 5 million meals for our 16,000 clients, children, and caregivers. This equated to roughly 17,000 meals that were cooked in our kitchen every day and then packaged and delivered by our fleet of vans to our clients all over. So our drivers drove over 260,000 miles to bring our meals to folks who really needed them. And as chronic illness continues to evolve, so do we. So we've expanded our list of eligible diagnoses to be nearly 400 different chronic illnesses and diagnoses that we know medically tailored meals are a really effective intervention for. I'd like to acknowledge that all of this work is made possible through the help of our volunteers. So last year we had 23.5 thousand volunteers come into our facility and help us carry out our mission, which brought meals to individuals all over who really needed them. And in order to talk a little bit more about the medically tailored meal intervention, which I know I've touched on briefly, I'd like to welcome Emily Jones, who is our RDN, or Registered Dietitian Nutritionist here at God's Love We Deliver, to give a brief overview of what medically tailored meals are and what that intervention consists of. So I will start the panel discussion by passing it over to you, Emily.
Thank you so much, Makenna. A medically tailored meal intervention includes both the MTM meal itself and nutrition interventions provided by registered dietitian nutritionists, also known as a RDN. Medically tailored meals are delivered to individuals who live with severe, chronic, or complex illnesses and experience activities of daily living limitations as deemed necessary by a healthcare professional. MTM meals are analyzed by RDN to ensure they adhere to the evidence-based FMIC standards and optimal nutrition value to promote health and recovery is provided. Maya will go into more detail about the FMIC standards later on. For the nutrition intervention, the RDN follows a standardized framework to provide quality nutrition care called the nutrition care process. It is through this process that the RDN conducts a nutrition assessment. The assessment informs the RDN on how to tailor the client's meal plan to meet their specific medical needs while accounting for cultural and religious preferences. Things considered when designing a client's meal plan include medical history, lab values, allergies, food preferences, medications, and more. It's important to note that only RDN is authorized to administer such nutrition-based treatment plans that manage or treat chronic health conditions, which can also be referred to as medical nutrition therapy.
Thank you, Emily. That was a great overview, and I think it's important to acknowledge that managing chronic illness is really difficult and complex, especially if you have unmet health-related social needs. So having the support of a registered dietitian nutritionist to walk you through that process while also tailoring your set of meals to the specific needs of the client is really critical in making that process more manageable and more equitable as well. So thank you for that overview. I'd like to bring it back quickly to the 1115 waiver. So on the screen, you'll see some examples of the populations and the diagnoses that will be eligible for those enhanced services. So those services that CBOs will be delivering to eligible Medicaid members. A lot of these populations and diagnoses are ones that we have been serving for decades. So there are things like HIV/AIDS, congestive heart failure, COPD, cancer, and more, which have been part of our model in our organization for years. Emily gave a great intro to the medically tailored meal model, which again is backed by evidence-based guidelines and meets really specific standards for the quality and the type of meal that is delivered to our clients. God's Love We Deliver is a Food is Medicine Coalition accredited agency, which means that we do meet really specific standards for the quality of our meals that are delivered to clients. So this is a great point for Maya to come in and tell us a little bit more about what the Food is Medicine Coalition is and what the standards for accreditation are. So I will pass it over to you, Maya.
Thank you so much. So as the FMIC representative, I'd love to give an overview just really of what FMIC is so everyone can become familiar. So the Food is Medicine Coalition, or FMIC, is a national coalition of nonprofit organizations that provide medically tailored meals and groceries, but then also medical nutrition therapy and nutrition counseling and education to people in communities across the country with severe and chronic illnesses. We advance equitable access to these life-saving interventions through policy change, research and evaluation, and then also best practices, which is where accreditation falls in. So FMIC has actually launched the first MTM intervention standard and then the subsequent accreditation program just this past year, which includes the previously existing medically tailored meal nutrition standards, which we have maintained for quite some time now. FMIC agencies actually created the medically tailored meal intervention over 40 years ago, and we are known for the impressive research outcomes that our nutrition programs produce. These results are only possible with nutritious food, community connection, and then a client-centered approach, all of which the standard codifies and then also offers to the field as a guidebook for meeting community needs. We really were intentionally releasing it as a guidebook for people to reference. Next slide, please. Thank you. So the FMIC accreditation program and the standard, it ensures excellence for our clients. It synthesizes decades of quality service provision into a standard for the field that ensures fidelity to the MTM intervention. Meeting the requirements of the ACR, which is the standard, ensures excellence for our clients who are at the center of the entire standard. The ACR ensures that regardless of location, size, or number of clients that an agency has, all accredited agencies prepare and provide a high quality MTM intervention that meets the needs of clients living with severe, chronic, or complex illnesses. So while the standard is rigorous, it is also flexible enough to ensure culturally relevant services that meets the nutrition needs of diverse populations. The ACR is central to scaling and equity of access across the nation because right now, healthcare reimbursement for this life-saving service is not universal or widely accessible. So it is vital that agencies be both able to partner with healthcare and also feed people for free. And then the standard provides verified credibility for an organization's operations. So it signals to the community, policymakers, healthcare partners, and most importantly, clients, a level of service that can be trusted. So what is the ACR exactly? It is a set of requirements and best practices. FMIC's goal is to support nonprofit providers into coming into conformity with the standard. And to reach accreditation, agencies must be in 100% conformity to the standard. So to become accredited, agencies must first undergo an initial audit to prove that they are in 100% conformity with the standard. And that consists of both a remote document review and then an on-site visit. I'm actually the FIMIC auditor, so I'm very honored to actually conduct that part of the accreditation process. Then to maintain the accredited status, agencies must submit a self-evaluation for 2 years to confirm they are continuing that level of conformity. Then finally in the process, on the 3rd year, accredited agencies must undergo another audit in which the whole process repeats itself. So it's a 3-year process. And then a little bit more detail on the standard itself. There are 8 pillars to the ACR, and it reflects the wraparound MTM intervention. FIMIC has tried to cover as much ground as possible when creating the standard, focusing on what makes FIMIC agencies unique in an objective and audible way. And to note, when I go through the pillars, there is no specific section on clients, and that's because they really are at the heart of it all in each and every pillar. So I'm going to quickly give an overview of the pillars. So there are 8. The first is general requirements. So these are just like baseline items to be a good nonprofit, covering topics such as a quality improvement program, training, and client experience. The second pillar is the fully integrated RDN. So this outlines that you must have an RDN or even several on staff, and then it shows how they must be embedded into your program. The third pillar is referrals, eligibility, intake, and then disenrollment. So these are a set of best practices and also timelines for each of those actions. Section 4 is the nutrition care process intervention. So this section echoes the Academy of Nutrition and Dietetics processes, and then it delineates how to fit it into your MTM model, because the MTM intervention is more than just a meal. Section 5 is medical tailoring. So these are the meal quality standards and qualifications for using the nutrition standards that are contained in Annexes 1 and 2 of the ACR. So it's a standard within a standard, just to complicate things a little bit. Then pillar 6 is food safety. So it outlines exactly that. Obviously, most people receiving services from FIMIC agencies are immune compromised, seriously ill. Having an entire pillar dedicated to ensuring excellent food safety was absolutely paramount. Section 7 is volunteer services. As Makenna highlighted, volunteer services are just of paramount importance to the MTM intervention. So it outlines how to incorporate that resource into your program. And then Section 8, finally, is HIPAA compliance. It outlines how to comply with HIPAA and support clients through a connection to healthcare. And then finally, I just want to touch upon the FIMIC nutrition standards specifically. So within the ACR, within the standard, it requires that each agency develops their own menus that are appropriate for their specific communities. However, no matter the menu, all meal plans must conform to the FIMIC nutrition standards, which are found in Section 5, medical tailoring, and then they are held as Annexes 1 and 2 of the ACR. And these nutrition standards are based on recommendations from the FIMIC Clinical Committee, which is comprised of RDNs of FIMIC member and accredited agencies across the country. So they review and revise the FIMIC nutrition standards based on evolving nutrition science from sources such as the American Heart Association, American Diabetes Association, dietary reference intakes, therapeutic lifestyle changes, DASH eating plan, the list goes on and on.
Thank you so much, Maya.
Thank you so much.
That was a wonderful
Thorough.
overview of FIMIC and of the accreditation standard and program. So thank you for that. And now I am really excited to have Catherine Couch here because she is in the unique position of being in a state that has had a waiver implemented for a little bit of time right now. So, Catherine, I'd love if you could introduce us all to Ceres, and then I'll stop sharing. And we'd love to hear more about your key insights and takeaways from the waiver so far in California.
Awesome. Thank you guys so much. And I'm really happy to be here. And hopefully some of what I share will be helpful to all of you as you launch your 1115 waiver in New York. Situations are a little bit different. We don't have these, network leads in different regions, but I think many of the experiences will be the same. So to start with, Ceres Community Project is an 18-year-old agency. We are members of FIMIC and very, very close to being accredited. And so really excited about that. We are a broad food as medicine provider in Northern California. So we cover 4 counties and provide about 225,000 meals a year. We do meals, groceries, produce prescriptions, medical nutrition therapy, and community nutrition education. And we're 100% organic, which I always like to share with people with that broad perspective about the power of our food choices to really create health for people, communities, and the planet. We have been involved in the work around 1115 waivers in California since 2017, when we began a conversation with our state, which led the Department of Healthcare Services, which oversees Medicaid in California, to conduct the first in the nation statewide pilot of medically tailored meals with Medicaid members with CHF. And so that laid the groundwork for the work that our state moved forward, launched in 2022. We were early contractors. We have one Medicaid plan that covers actually now 24 counties in Northern California. And we contracted with them in late 2021 and began to work with them in about February of 2022. I'm going to talk a little bit about the contracting experience and kind of what that trajectory has been like over the last 3 years. And then I'll talk a little bit about some of the lessons learned. Our plan is great, really committed to working with locally based organizations. And it is a lot for plans to take on this new area of work. We had people we were working with at the plan, and the idea was we were going to, so our process is we get medical referrals, we submit a treatment authorization request that gets approved by the plan, we provide the services, then we submit a claim, we get paid. And so the idea was to take 10 test TARs and move them through the system and work out the kinks of the way. So 5 months in, we're still in that process of the first 10 TARs. And so our team was trying to work very graciously with the plan. And so finally, about 5 or 6 months in, we were like, okay, it's time to do a little intervention here. And we created this very gracious email that kind of laid out everything we'd done and all the timeline steps. And, credit to the plan, we had a response back within a couple of hours. We set up a meeting the next week, and they had people from claims, they had everybody there on this call. And things then started to streamline. And I think one of the things that I would say is don't be passive in the process, right? Whether it's the network lead that you're working with or someone else, but to stay in communication and to let other people know how it's going and where the roadblocks are on your side. We were able to kind of quickly get going, and just our trajectory was we billed about $100,000 at the end of 2022, $560,000 in services in 2023, $760,000 in 2024 this year. And now we're planning to actually double billing next year to really, really scale up now that we've got all of that in place. We did bring on new staff. We were very, very lucky that our chief program officer had been in a federally qualified health center. We hired away from that same federally qualified health center their director of quality, who now is our contract and business development manager. And in the past year, and then a couple of years ago, we brought on a data analyst. There's a lot of data to manage. And we also have now brought on a medical biller. So there's just a whole new staff that's needed to really manage these kinds of services and these kinds of relationships. We were lucky, and I think most states who are doing 1115 waivers have capacity building funding. In California, that came through 2 channels. The plans had money that they could give away called incentive payment program. And then the state also has a big granting program. And we got 2 rounds of funding through both of those. Those paid for new staff for a year, sometimes up to 18 months, or staff in new roles. It paid for things like, if you needed kitchen equipment, we actually got a 3rd refrigerated van through that funding. And then also all the IT capacity building that we had to do, and new workflows and all of that. What else do I want to say? We'll talk a little bit about lessons learned, I think. So one of them, so in California, like a lot of states, we did in our previous waiver, we did what are called whole person care pilots in 14 counties, and also health home pilots in a number of counties that were kind of the baseline for this health related social needs stuff. And California has 58 counties, and somebody that I know has a graduate researcher who looked at what counties are really doing well right now in the waiver and compared to counties that are not, and tried to look at what those correlating factors are. The only correlating factor is the 14 counties that had whole person care pilots in the previous 5-year waiver. And I share that to say that this stuff takes time, right? It takes time to build the relationships, the referral pathways, the relationships with your plans. This is a marathon, not a sprint, and we've got to be patient. And it's really about trust and relationship building really across the field. The second one, which I referenced earlier, is communicate regularly and often with your plan partners or your network lead entities. Let them know what's working, what their stumbling blocks are. We all have the same vision here. Everybody wants to have this work. And if they don't understand where your roadblocks are and what's happening, they can't help. I mean, we recently had a problem, like, our plan is scaling a lot, and they were a little bit short-staffed. And one of our claims got double paid and then denied, and it was like a mess. And our team tried to kind of work gracefully through the whole thing. And, finally we had to just say this, we had to call a meeting. And as soon as we called the meeting and got the right people in the room, it got cleared up. We're back on track. And so my thing is, like, don't wait, communicate often and frequently, but also about what's working, and tell success stories. We've just done a big pre-post analysis with a lot of the plan members. We're sharing that with the plan so that they also understand the patient experience and the value of the services. The last thing I'll say is we have to all keep in mind that our state, our health plans, our providers, this is not traditional clinical care. They don't know how to think about food. They don't know how to think about these services. They sort of do, but they don't really. And so every conversation we're in, we really need to take that time to share patient stories, right? Of the details of why this makes a difference for a patient and what can come out of it, so that we really build buy-in. Like, this is amazing that this is happening, and plans and states are paying for these services, but we have to bring the whole healthcare system along about why that's really important and what the value is. And that's the opportunity that we have with these waivers. So I think I'll stop there, and hopefully that was enough kind of baseline, and open it up. And I'm happy again to share answer any questions that people have as someone who's 3 years in to this lovely process.
Thank you so much, Catherine. I think that is really helpful as the waiver nears very soon. So that information was wonderful to hear. And I loved your point about bringing it back to the CBO. This is where we've been operating for so many years. We know our services. We know that these interventions are effective and work when implemented properly. So I think that's a really important point for everybody on the call. And I thank you for your experience and your knowledge.
Absolutely.
Yeah. So we do have a few questions, so we will go ahead and start with those. The first I will ask to both Emily and Catherine, but this is just, can you speak to what foods comprise medically tailored meals? So I'll let Emily go first.
So at God's Love, we avoid ultra-processed foods, fillers, preservatives. We provide whole foods to promote a balanced diet. I would say as a FEMIC accredited agency, we ensure all of our meals as a default are heart healthy, therefore they're low in sodium and fat, and they're also appropriate for people with diabetes. I know lots of our existing clients or even a lot of other people that might come to us would definitely love for us to serve like a bacon cheeseburger. Definitely be a fan favorite, but our goal is to provide medically tailored meals that promote health and recovery. So that's why we do, follow those FEMIC guidelines. And I'll pass it over to Catherine for her input.
Yeah, very, very similar. As I said before, we do 100% organic, 100% whole food, all whole grains, so no refined carbohydrates, very, very little sugar. Our baseline meals are also heart healthy and diabetic friendly as a baseline. We're very plant forward. I always say to people, most people are not lacking in protein or carbs in their diet. Most people are lacking in vegetables. And so we view part of our job is introducing people to that vegetables can taste great and get people to eat more of them. Yeah, I think that's it. And then within, each of the diet categories, each meal is then carefully tailored to meet the specific nutrition standards, whether it's chronic kidney disease or diabetes or another condition.
Yeah, that's great. Thank you both for that. Yeah, and I think it's important to talk about the fact that, there are some clients who have several different comorbidities. So part of the work of the medically tailored meal intervention is really layering all of those modifications to best serve the needs of that client. And everything that Emily and Catherine just mentioned goes into that. So thank you both for that answer. The next one is actually about medically tailored groceries as an intervention. So I will hand that over to Maya to talk a little bit about the MTGs.
Thank you. So right now, MTGs are not really defined the way that MTMs now are through the MTM standard and accreditation process. That's what the standard does. It defines MTM. So MTG does not have a standard that does that. And it's a very prominent intervention across the country, more prominent than MTMs are. So FEMIC actually has recognized all of this. And in the new year, we're actually going to be opening up membership for medically tailored grocery providers by application to ensure like high quality programs are joining the coalition. Because we recognize that MTGs are a key intervention in the food as medicine spectrum, and we want to support providers in delivering that service by really giving them a community of practice, and that's what FEMIC does. And then a unique benefit of coming into FEMIC membership as an MTG agency would be the opportunity to participate in the planning of an eventual MTG standard to define that intervention.
I will just add to that. I mean, I think, again, when we talked about food quality before, we use those same food quality standards in our medically tailored grocery bags. What is harder to do, I mean, you also can't control that somebody eats a whole meal, but what's harder to do is to control how people put those pieces together into a meal, right? Because we can't control what's happening on the other end of that. But all of our groceries meet those same standards: no processed foods, low sugar, whole grains, lots of vegetables and fruit, lean protein, all those things, low sodium. And so we're still trying to put those high quality foods in people's hands.
Thank you both for that. FEMIC is really great in that it's an organization that can develop these standards. So we know that when people are receiving medically tailored meals and medically tailored groceries, it means one thing, and that one thing is the high quality intervention. So we appreciate your insight on that aspect of nutrition services. We have a few more questions that came in on, again, more lessons and tips for billing services. So Catherine, if you have any additional insight on that, I know you mentioned a little bit of the billing previously, but we'd love to hear some more insight.
Just in general, it is important that you have a database system that allows you to track all of the services being provided to your clients in a way that you can extract that data and pull it into a claims billing. Or in California, when we started, CBOs could invoice by like an Excel spreadsheet as opposed to claims. We contracted with someone to, we wanted to go directly to claims, and so we built that capacity internally. The other thing that there's a lot of complexity around the eligibility, and that's also different in different states. But the process for bringing in a referral, screening that person is eligible, submitting that request, getting it approved, and then on the billing side, again, good data tracking. And the other thing that we've been working on, and I don't know if this is true in New York, but in California, plans can approve an initial 12 weeks of service, and then the service can be reauthorized for another 12 weeks. So that reauthorization part is one that we're still working on. What does the plan need to see? And what is the data that the RDN needs to be providing, either in RDN notes or in terms of labs, to get the plan to say that, for example, someone who's diabetic and overweight, who's successfully losing weight, should get another 12 weeks of service. And I think those are, again, conversations with your plan, that you learn to talk a similar language, or at least hear each other on what that is, so that you can come to a common understanding of what's required to move that forward.
Thank you, Catherine. I'm sure there will be many hiccups along the way, but of course, as soon as we get into this and start to learn what works best and what best practices will be, I'm sure we'll all develop our own insights for billing in different portions of the waiver. And in New York, actually, we have the ability to serve for 6 months with the option to reauthorize for another 6 months. So yeah. Another question we have is, who decides what meals the clients get? And we talked a little bit about this during the presentation, but I will let Emily speak a little bit more to that process.
Sure. So the RDN and the client collaborate to determine what meals is best. So this is kind of at the outcome of the assessment. So the RDN is able to inform the client as to what's best from a nutrition standpoint to manage their illness. And then the client is going to bring their personal preferences and limitations. So it's going to be that, dialogue that happens. But the ultimate goal at the end of that is to provide the least restrictive meal plan that will still promote the client's health.
Thank you, Emily. Yeah, as Maya stated, as Catherine stated, and as Emily stated, really the client is at the core of this. It's about finding what works best for them in terms of what they like and what's appropriate, but also in what will best manage chronic illness. So it's important to recognize how integral the RDN is to that process, and to making sure the meal intervention is the most appropriate and effective that it can be.
And I would just add, and Emily, I think you can chime in on this too, but one of the things we're really good at is having that initial conversation with the client. Our client care teams always say, tell me about what you're eating now. And we tell them what are the kinds of meals we're going to give them and why those meals are important for them. So building that early buy-in and those really important conversations that our client care team and then our RDNs have with our clients, to help them understand how we motivate them to try things that might be unfamiliar and maybe not initially palatable, and then get them to have that experience over 2, 3, 4 weeks where they realize they actually feel better eating this way. That whole hand-holding process is a really critical piece of the way we wrap around clients to support their success with what is very, very difficult dietary change, right?
Absolutely. That is exactly how all of our RDNs at God's Love operate. Not only do we have that initial kind of introduction and assessment, but we offer ongoing nutrition counseling. So we literally hold them, every single step of the way. We have check-ins, we do try to personalize this. So we understand, yes, as a clinician, we have to review, the not so great stuff, the labs and your progress, but, we are their champions, we are their ear, their shoulder to lean and cry on. So to kind of get them through, what they need to, again, refocus on their diet and make those difficult changes. And we also see not just the individual, but the entire household. So when we do serve, the caregiver or the dependent, it's really buy-in for the whole family. So then they all become as a unit, a champion for this change, and, growth. And it's a beautiful thing to see, that just unfolds right before our eyes.
Thank you both. That was wonderful. And we know that access to healthcare is a really difficult thing, and then access to dietitians and reputable nutrition practitioners as well. I mean, it's expensive, it's not frequently accessible, so it's so important to be able to have an outlet where somebody can walk you through that process, get to know you, know what your current, operation is, and then move from there. So thank you so much, both of you, for that answer.
I'd also like to chime in really quick as well, and just let everyone know that also FIMIC has partnered with the Center for Health Law and Policy Innovation at Harvard, so CHILPI, to create a comprehensive guide actually of existing state Medicaid authorities to leverage for increasing access to food as medicine services. So I am going to link, it's called the Food as Medicine State Medicaid Policy Toolkit. I'm going to link it in the chat now. I highly, highly, highly recommend everyone to take a look at it. So I'm popping it in right now. Thank you guys.
Thank you, Maya. We received another question about languages for the services that we offer. So I opened that up to any of the panelists to speak about how you accommodate diverse needs, whether that's language, health education materials, really anything.
Yeah, so in Northern California, our primary immigrant population are Latinx, Spanish speaking, and about 35% of our clients are Latinx and about 20% are primary Spanish speakers. So we've transitioned right now, 3 out of our 4 client care intake coordinators and 1 of our 2 RDNs are bilingual, bicultural. And the bicultural part is important, right? Not just bilingual. And that we think that, and all of our materials are in both languages. We think that's really, really important. There are a couple of other languages that are less common, but also important. And we use language services for those. It's pretty hard to have, for a very small population to have a staff member who's that population, but we use language services for those. But I think it's really critically important because we want people to feel welcomed and supported at a really difficult time that is hard on many, many, many different levels. And so that talking to someone from your own community who can speak your language is really a really, really important part of that service provision.
I can chime in and also just kind of echo everything Catherine just said. We operate very similarly at God's Love. We do have staff that speak, Spanish, as well as Mandarin. We do have nutrition education materials in those languages as well. And for any language that we do not have a staffer to speak, we do also have a translation line, to facilitate communication between our clients, or any other, caregivers or whomever are speaking on their behalf as well.
I'll just chime in really quickly to let you know that the FIMIC accreditation standard actually requires agencies to provide translation services, and then also to provide all written materials in the languages that are most commonly spoken by your individual specific community. So if your community speaks predominantly English, Spanish, and maybe Russian, all of your written materials must be available in those languages, and then you have to offer translation services to all clients.
Thank you, everyone. We have time for a couple of more questions. So we had one come in about the waiver in California. So Catherine, this question is, what electronic referral management system does California use?
I do not know the answer to that. So there are so there is, like you guys were talking about Unite Us, for example, we do not have systems like that. So I will just say we have driven our referral pipeline through our many existing referral partners. We have HIPAA compliant ways that people send medical referrals to us. And most of our referrals are coming through those channels, not through a Unite Us kind of platform. And California has no California is a very big state. We have no standards around that. One of the things that is happening in California, which is, I think, in some ways maybe mimics what you're doing in New York State, is various counties are setting up kind of hub models where someone is holding the administrative contract with a plan and then subcontracting to small CBOs who are providing services. One of the challenges in California is not all the plans are allowing subcontracts. And if you can't subcontract, you can't do one of those arrangements. And so very small CBOs, of course, it's a really big lift to stand up claims billing. And that's really closing the door for some of the providers who we really need in the system. So we're still trying to solve for that. California is also working on a whole big project around data exchange. And Ceres has signed on to the data exchange agreement. And so this will allow us as a CBO to directly access health claims information and be able to look up, for example, to see, were our clients in the emergency department room? What are their labs? And that is going to be hugely important as we, it's not going to solve the problem overnight, but as we build that capacity to be able to, again, make a case for why someone needs an extension, to kind of advocate for eligibility for certain clients and things like that. So again, this is, when you look at the big trajectory of healthcare transformation, CBOs are now, one of the ways someone said it to me recently is CBOs are a new provider group in Medicaid, right? We are bringing in this whole class of organizations that are now part of the healthcare ecosystem. And that is all kinds of capacity building, but also we also need access to that same data, right, in order to advocate for our patients. So no unique referral system that we have in California.
Thank you. And then I'm looking at the Q&A just to see if there are any other questions that have trickled in. I think most have been answered either by us or by Allison. So I'll give the panelists an option if they have any takeaways they'd like to leave off on. I invite you to give your feedback now or your insights right now. I know we've said a lot and we've really spanned many different topics. We hope the information was helpful for all of you on the call, but it was great to hear from each of you, and all of your experience is so important and special to learn about.
I would just say good luck as you embark. It's really important work that we're doing. That's really transforming how we think about what healthcare is. And it makes a huge difference for our patients. I think this piece around really standing in the knowledge and expertise that you have as community-based organizations. God's Love has been doing this work for 40 years. We've been doing it for 18 years. We are experts in what our patients need, what our clients need. We're expert in the provision of services. Most of us already work with many healthcare providers as referral partners. And so just really, there is a lot of venture funded for-profit competition coming into the space. And that intervention, someone drop shipping meals to your door is not the intervention we provide. We, as Emily and I have shared, we wrap around members, we hold their hands, we listen to them. We have community members who deliver those meals to their door. We include cards and flowers in our bags. Like, there's a whole experience that our clients have that is very different than the experience of someone, FedEx dropping, 7 meals and packaging at your door. And those differences actually matter for people's health, their mental health, but also their health outcomes. And we need to stand in and really value that knowledge that we have about that and stand up for it, I think, in this moment.
Thank you so much. That was wonderful. And I think we can all agree that we have been existing in this space for so long, and these services aren't new to us. This experience and this opportunity is new and exciting, but these are things that we've been doing for so long. So I will just wrap up by sharing my screen really quickly. So this past week at God's Love, we actually celebrated our 40 millionth meal, which is very exciting. Next year is our 40th anniversary. So we've been around for so long, we've been delivering meals for so long, and the fact that we've delivered our 40 millionth meal is something we're really proud of. We're really excited for the opportunity to participate in the 1115 waiver. It's not changing who we are at our core, but it's allowing us to expand our mission and bring services to those who might not have received them before. So we appreciate everybody for being here. We're excited to enter into this new waiver chapter and see what happens. And I really appreciate each of you on the panel. You all gave us such impactful information and takeaways. So thank you so much.